body, less head. And we have 3 companies that manufacture the DEXA machines, and this is very important, it is not an advertisement. Lunar machines, Hologic and Norland. Norland is a very minor provider, and so we are left with lunar and Hologic machines. And they cause problems when we assess a patient repeatedly, okay? Because there are problems during data acquisition. For instance, the machine calibration. The lunar machines, they give a higher bone mineral density readings than the Hologic machines because they are calibrated to ash bone. The Hologic are calibrated to hydroxyapatite, and so the results are different. If we look here, with the Hologic machine, if the person has a bone mineral density of 0.6 grams, he is osteoporotic, while with the lunar machine, he has to have a 0.7 gram to be osteoporotic. The magnification again will cause us problems. Magnification means the beam, because this is the region of interest, which is outlined in yellow. The beam will diverge according to the size of the bone. And because it is an aerial bone mineral density, not a volumetric bone mineral density, it will differ. These tubes have the same bone mineral density, but this tube will give us a bigger area, and this will give us a smaller area. So the area density here will be higher than here. So we cannot compare a child who is small even to the children of similar age. We have to compare him to children of similar height. Quantitative computed tomography is very nice because we can measure just cortical bone. We can choose a region of interest, just the trabecular bone, or the cortical bone. It gives us a volumetric bone mineral density. It's very nice. However, the radiation exposure is very high. If you are doing repeated measurements, this will be not very good for children. However, peripheral quantitative computed tomography is better. It gives less radiation and it's suitable for children. Again, we can differentiate between trabecular and cortical bone. Cortical bone is present in the metaphyses, while the diaphysis is mainly formed of cortical bone. And here we can see that the trabecular bone is not affected. However, if we look at the cortex, we'll see that it is very osteoporotic. And because different disease pathologies will cause different affection, thalassemia mainly affects trabecular bone. Growth hormone deficiency mainly affects cortical bone. So quantitative computed tomography is better. However, it's not. The problem with it is that it is not calibrated. Lack of reference data. If you use DEXA, you'll find a lot of reference data that you can compare your child with. However, if you use quantitative computed tomography, you have to have your own references. So it's very difficult to be used. Again, 2 studies in thalassemia compared DEXA with quantitative computed tomography, that is peripheral quantitative computed tomography. One of them found a very big difference, where 44% were osteoporotic with DEXA, only 6% with quantitative computed tomography. However, another more recent study found that they parallel each other. And to this point, up to now, the only the recommendation is that we use DEXA because it's safe, it has reference data, and it's proved to be reliable. So how can we interpret DEXA scans in children? The most important is that in the report we do not want to have a T-score. You see here the T-score is -5, while the Z-score is -1.7. If someone who is not very familiar with a DEXA report will consider the child osteoporotic based on the T-score. The regions we use are the spine from L1 to L4 and total body less head. We don't like to use the femur, neck of femur, and in children because this region is progressively growing in children. And if you repeat the measurement after 1 year, you'll find that you cannot get the same region of interest. And the minimum time interval before repeating a scan is 6 months. It's better to repeat after a year, but the minimum time interval is 6 months to get a result. And also to be considered significant, the percent change in bone mineral density should be above the precision of the machine. That is, if the precision of the machine is 1 to 3% in the spine, you should have a change in the bone mineral density above 3% to consider it significant. We'll take an example here. A child with juvenile rheumatoid arthritis, a girl who is 11 and a half years, and when they did the bone mineral density Z-score, it was -3, her height Z-score is -5. They adjusted the bone mineral density to her height, and it was found to be -2.2. Still, she has low bone mineral density. Another child with a Malone syndrome who is 14, and his bone mineral density Z-score according to his age is -3.2. When they adjusted it to his height, it dropped to -0.7, so he's completely normal. And this shows us that with correcting to the height, if we use the height age, then short children will have more or less normal bone mineral density. Also, another important point is to use the same machine every time you do a DEXA scan. You don't use a hologic machine one time and then for the other scan you use a lunar machine, it will give different results. And children with thalassemia should be scanned starting from the age of 10 years, or if they fracture, or whichever is earlier. So how to maintain bone health in thalassemia? We have to, the risk factors we have are ineffective erythropoiesis with bone marrow expansion, the endocrine complications which have been mentioned, the iron overload, vitamin deficiencies, and the decreased physical activity. So we have to correct all these factors. We have to encourage physical activity. Weight-bearing exercises, just to encourage walking is enough. We have to give adequate calcium up to 1,000 milligrams per day, to give adequate vitamin D, 1,000 international units per day, and they have to maintain a healthy lifestyle. If with this intervention we still have deterioration in bone mineral density, we should resort to pharmacological intervention. Of course, the idea in children is to use an anabolic agent. However, the only anabolic agent available is parathyroid hormone or telecanthine. However, it has a black box warning that it should not be used in children because it can cause osteosarcoma. It causes osteosarcoma in mice. But it's not known if it is dangerous in children or not, so we are left with the bisphosphonates, which are anti-resorptive agents. We have increased osteoblastic activity in thalassemia, and so bisphosphonates are the best choice we have. Bisphosphonates will cause apoptosis of the osteoclasts. Also, they are deposited in the osteoid, the mineral that is deposited in the bone, and so with further resorption of bone, they will be released, so they will have an extended half-life in bones. We have the bisphosphonates. We have two types. Either we can give them oral or intravenously. The oral formulations we have are phenidronate and zoledronic anandronate and risodronate, or Fosamax and Actonel. These are the oral formulations. They have weekly formulations. That is, the Fosamax is 70 milligrams and the Actonel is 35. It's better to be given once per week. This will aid compliance and will decrease the side effects, because as we know, they have to be taken on an empty stomach. The child should be sitting because they can cause ulcerations in the esophagus, and so giving them once weekly is better. I prefer the intravenous formulations, either phenidronate, not available in Egypt now, but we have zoledronic acid or Zunita. The aim with bisphosphonate therapy is to increase bone mineral density by half to 1 standard deviation score per year. The doses are phenidronate, the 1 milligram of phenidronate is equivalent to 0.025 milligram of zoledronic acid. And in osteogenesis imperfecta, the usual protocol is to give 1 milligram per kilogram on 3 consecutive days every 2 to 4 months. However, we can use just a single injection of 1 milligram per day every 3 to 6 months. That is very suitable and enough. For zoledronic acid, it has been studied in thalassemia, and they found that in adult patients, giving 4 milligrams, that is 1 ampoule, every 3 months will increase the bone mineral density. They used it in children at the dose of 0.025 milligrams at 3 months intervals, and they found that this regimen was safe for 2 years. However, because children are growing, and if you stop treatment after 2 years, the newly formed bone will be fracture at the site where the newly formed bone is formed and the treated bone is present. So it's better to continue treatment in growing children till they fuse the epiphyses. And a proposed treatment is to give 0.025 milligrams per kilogram every 6 months. That will be all through the growing period. That will be a very good regimen. Of course, we have potential adverse effects, but what we have to look for very well is hypocalcemia. They can cause hypocalcemia, so we should assess the calcium, the phosphorus, the alkaline phosphatase before we give any of these bisphosphonates. Also, we have to assess renal functions, because with renal impairment, they are not suitable to be given. And thanks.
Thank you very much, Professor Heda, for the nice presentation about bone disease and thalassemia. And may I introduce Professor Khoury, Professor of Pediatrics and Pediatric Endocrinology at Chelsea University. The topic is guidelines for treatment of endocrine abnormalities and complications in patients with thalassemia.
I would like first to thank Professor Ahmad El-Bishnawi for inviting me to this great congress. So I set guidelines for the endocrine complication in thalassemia. The ICET is the international network on endocrine complication in thalassemia. It was founded in 2009. Its members are from Egypt, from Qatar, from Italy, from Iran, Turkey, and Greece, and Cyprus. The objectives are to train pediatrician and the physician and hematologist to the endocrine complication, to prepare guidelines, and to collect the data on the growth disorders and endocrine complication in different countries, and to encourage research. The following ICET recommendations are an effort based on current evidence and existing guidelines. My lecture will be how to screen, to monitor, and to manage endocrine complications. This is carried by a multidisciplinary teams of endocrinologists and hematologists. A recent survey conducted by TIF on more than 300 patients, it was found that 56% are seen by an endocrinologist, and half of them only are seen annually, while the rest is seen to be followed occasionally. So it is important that the physicians are aware that endocrine abnormalities may develop, especially in patients with overload and or poor compliance to clinician treatment, particularly after the age of 10 years. This topic will consist of the screening and the monitoring of growth and of specific endocrinopathies. We'll start by the gross assessment. The patients are assessed for gross every 6 months to 1 year. We record the parental height. We take accurate measurement of the standing, sitting heights, weight, and head circumference at each visit. And this is the correct way to measure the standing height by a centimeter, and the daily calibration is very important. The patient must be in this correct position, the head in the frontal plane, the head, shoulder, buttocks, heels touching the wall plate, arm, sides, and legs straight and knee together. And this is the sitting height table to measure the sitting height and accordingly the upper and lower segment. We plot the gross data on the local or in the national charts, and this is an example of a patient with thalassemia, a girl. She was on the 3rd percentile, and after optimizing the treatment, her gross improved, and she is now on the 75th percentile. And lastly, we calculate the gross velocity, the BMI, and the upper and lower segment. And this is a boy with the thalassemia with a delayed peak, and if you look, here the spurt is delayed for 2 years, and we also can relate the upper and lower segment ratio to diagnose the proportionate short stature from the disproportionate one with a short trunk or short limbs, and these are common in thalassemia. If you look to this patient with the thalassemia, he is short and he has a skeletal dysplasia, and if you look to his arm, and here the humerus is very, very short. So, to summarize, a child is considered short if height is less than the percentile of 2 SD below the mean for age and sex. Even if the height is normal, but the gross velocity is below the 25th centile, and if the patient is short from the mid-parental height, although his absolute height may be within norm. Now, testing and evaluation of specific endocrinopathies. And these are the glands which are affected by hemosiderosis in thalassemia: the pituitary, pancreas, adrenal, parathyroid, thyroid, and the gonads. And these are the prevalence of the endocrine complication presented by a study of TIF in 2004, and as you see, hypogonadism is the most common in endocrine complication. The affection of the pituitary will lead to growth failure and hypogonadism. About growth failure, the short stature is about 25% of the patients, but not all patients are growth hormone deficient. So we must evaluate the cause of short stature, and this is done by dietary assessment, CBC, blood chemistry, electrolyte, calcium and phosphorus, renal and liver function tests, urine and stool analysis, thyroid function, and bone age by X-ray, and and also X-ray of the tibia and the spines to exclude skeletal dysplasia. We treat the underlying cause if it is hypothyroidism or diabetes or chronic illness. We refer to endocrinologists for growth hormone determination and treatment. And mind you that the growth hormone treatment is not always as effective as in non-thalassemic children with growth hormone deficiency and may result in decreased insulin sensitivity and abnormal glucose tolerance. This is a typical curve for a patient with a growth hormone deficiency, and if you look, you will see that the growth decelerates by the age of 9 to 10 years. Now, hypothyroidism, the evaluation of the FT4 and TSH is recommended annually at 9 years or earlier if asymptomatic. The majority of patients have primary thyroid dysfunction. If it is subclinical with a high TSH from 5 to 10 with normal free T4, this will just require a regular follow-up and optimizing the radiation therapy. In overt hypothyroidism, we give thyroxine. A hypopara usually presents in the second decade of life, and the majority of patients present with mild hypocalcemia and paresthesia. Severe cases may present with ventricular failure and intracranial calcification. So regular checking of hypocalcemia is important. The diagnosis is based on low serum calcium, high phosphate, and low PTH. The management, as you know, is by calcitriol and calcium. We must keep the calcium in the low normal range. We must keep the calcium creatinine ratio below 0.2. And the diet must be rich in calcium and low in phosphorus. Diabetes mellitus is seen after the age of 10 years, and it is usually a combination of insulin resistance and islet cell insufficiency. In 2-hour oral glucose tolerance testing should be performed at 10, 12, 14, and 18 years of age and annually thereafter. The fasting glucose above 125 is a diagnostic of diabetes mellitus. At 2 hours between 140 and 200 indicate glucose intolerance, and above 200 indicates diabetes. The management is by strict dietetic diet, a regular physical activity, and an intensive relation with erythromycin and deferiprol. There are limited data on oral anti-diabetic drugs, and the insulin therapy is indicated in symptomatic patients with persistently elevated glucose when all other measures fail. A periodical monitoring of the metabolic control by glucosamine and regular assessment of renal function and evaluation of erythropathy is important. Now the adrenal insufficiency, the clinical adrenal insufficiency, the adrenal crisis is very, very, very rare. And the manifestation of the mild hypofunction might might be masked by symptoms commonly complained by these patients, such as fatigue, muscle weakness, and weight loss. So screening of basal cortisol and cortisol after stimulation is important, and especially in patients receiving growth hormone treatment. The clinical impairment of the adrenal is of little of clinical importance under better condition, but may have a potential relevance during stressful events. So, glucocorticoid treatment coverage might be advised only for stressful conditions. Finally, hypogonadism. It is usually a secondary, and it is the most common complication. It presents as a delayed puberty, slowly progressive puberty, arrested puberty, or infertility. So thalar staging every 6 months must be done from the age of 12 years. A hypothalamic pituitary gonadal function is assessed in case of delayed puberty at 13 years in girls and 14 years in boys by basal LH, FSH, GnRH, the test, and bone age, and the pituitary MRI. And other causes of delayed puberty as chronic illness of malnutrition or thyroid dysfunction, etc., must be investigated. This is a typical curve for a delayed puberty with a deceleration at the age of 12 years. The management, as it was said in the previous lecture, is by testosterone in boys and ethynyl is estradiol in girls. And it was found by Professor Bishulabi that it may have a positive effect on puberty. Now, as a result of recent improvement in medical therapy, patients with transfusion-dependent thalassemia are living longer, and they want to be married and have children. So management of the fertility and pregnancy became an important issue. Patients should be assessed for the suitability of pregnancy with optimal outcome for the patient and the mother and fetus. Induction of spermatogenesis in males and ovulation in females should be undertaken by a specialist. A cryopreservation of sperm should be recommended in all thalassemic patients after induction of spermatogenesis. To conclude, a gross assessment must be done every 6 months to 1 year. A thalar staging every 6 months from the age of 12 years. Annual endocrine screening from 10 years or earlier, if indicated, for fasting glucose, serum calcium and phosphorus, bone mineral density by DEXA, and fasting cortisol, the serum TSH and the free T4 by 9 years of age, LH, FSH, and sex steroid at pubertal age. Patients with abnormal screening are referred to endocrinologists for further evaluation and therapy. The take-home message. Number one, optimizing the treatment. And this is very important. If you look to this study done by Gamberini and DeSantis in 2008, comparing the prevalence in the 80s and 2007, with optimizing treatment, the primary hypothyroidism decreased from 6.5 to 0.9%, diabetes from 3.9 to 0.8%, hypopar from 2.4 to 0%. Another study by Farmaki, it was found that normalization of the total body iron load with intensive combined chelation, and especially with the combination of desferrioxamine and deferriprone, reverses the cardiac and the endocrine complications in thalassemia measure. The third point is early diagnosis and treatment of endocrinopathies. Look to this patient with a late diagnosis, late treatment, and bad compliance. It results in a very short patient with severe hypogonadism and azoospermia. The third point is management of fertility and pregnancy. So these 3 points are essential to achieve a good quality of life in a thalassemia patient. Finally, this ICET guideline for the endocrine complication in full details are published in the Indian Journal of Endocrinology and Metabolism, and will be published in a few weeks in the Indosar. The Indosar is published by ICET. And thank you.
Thank you very much, Professor Farhad, for sticking to the time and for this excellent resume on the guidelines of endocrine disorders. But now we have even less patients referred to us after those excellent guidelines. And now the floor is open for discussion.
لو تاخد مايك او حضرتك تيجي هنا.
In replacement therapy in cases of delayed puberty, Dr. Ashraf was speaking about the protocol of replacement therapy of by testosterone and galactoline. Okay. The question is about modification of this protocol when there is deficiency in growth hormone to avoid premature of erections and implications of puberty, and in cases of hypothyroidism, as mentioned by Dr. Alia, first patient of thalassemia has subclinical hypothyroidism. So when take replacement therapy by testosterone and galactoline will induce deformity in their mood. Is there is a modification of this protocol when there is hypothyroidism or deficiency in growth hormone?
So the question is to Professor Ashraf.
Yes.
If I understand correctly, إذا في تعديل للبروتوكول of testosterone replacement in the cases with growth hormone deficiency and hypothyroidism in order to avoid premature closure of the epithesis. أنا فهمت سؤالك صح؟
تمام.
هو مش هيبقى فيه modification عشان انت بتدي testosterone replacement therapy at the age of puberty. So you don't give it early. You give it at the age of the normal puberty. And it is a replacement therapy, and you start with a very minimal dose and you increase gradually, so it will not affect the epiphysis. It will cause the fusion of the epiphysis at the normal age for fusion.
At normal height, not normal age.
And it will not affect the height.
At normal height and not normal aging. Okay.
احنا يعني دايما بنتابع برضه البون ايج اثناء الريبليسمنت ثيرابيز دي، فبتبقى اندفيدواليزد وتيلرد على حد لكل حاله، بحيث ان احنا لو لقينا ادفانسمنت يعني ادجست الانترفال والدوزج اوف ذا سكس ستيرويدز حسب استجابه كل مريض.
Thank you. Another question to Dr. Alia. Distribution of yes. Distribution about there was high percentage of your cases with poor chelation. About 20% of cases in your trial was poor chelation, and most of cases was having subclinical hyperthyroidism. But the relation between these two, distribution of hyperthyroidism among the distribution of
سليمان بس هو مشغول يعني في اجتماع مع الدكتوره امان، يمكن حضرتك تقدر تجاوب عليه يا دكتور محمد. هل عنده هو او حد عمل ترايل اوف IGF-1 ريبليسمنت للولاد اللي هم بدري
الطفل؟ هو يعني
هو عمل
انما يعني I don't believe in the IGF-1 replacement for the simple reason. The IGF-1 replacement in complete growth hormone insensitivity, like the Rose syndrome, is not as efficient as the growth hormone in growth hormone deficient patients, and the final height is not very good. في حد من البيشنت ورا في عنده اي سؤال حتى لو قالوا بالعربي؟ اتفضل. ممكن ندي لو في جروث هرمون ديفيشنسي، يعني لو يعني في نقص فعلا في يعني جروث هرمون فبندي جروث هرمون. لو اتلقى نقص والنتيجه ما بتبقاش هي يعني الطول النهائي بيتحسن شويه، انما ما نديش جروث هرمون اللي ما عندوش جروث هرمون ديفيشن لانه مش حاجه خالص.
الجروث هرمون اكسبنسيف عشان دي افكت على الانسولين بيعمل انسولين ريزيستنس، فهو يعني ندي ليه على اساس انه ليه سايد افكت؟
لا بيعمل انسولين ريزيستنت يعني انما بتبقى كنترول وبنقدر نظبط الدوز. يعني حتى اللي عندهم جروث هرمون ديفيشنسي وعندهم سكر بياخدوا سكر لغايه لما الابيفيز تاني. يعني في الولاد عند لغايه مثلا 16 17 سنه.
انا عندي سؤال للدكتوره هبه. دكتوره هبه النيورو اكسبيرينس واضح ان حضرتك اشتغلت كتير على بون سكان ثالاسيميا patients. What is your or the international recommendation to do a bone scan? يعني in what frequency, or is it only when there is a fracture?
Thalassemia recommendation we start at the age of 10 years. You have to start by the age of 10 years. The child fractures before this, you have to start
Any other question? Okay, thank you very much for your attendance, and the session is closed.
Firstly, I have the honor to introduce Professor Dr. Leila Sharif, University, to speak about nutrition and cancer and immunotherapy. And I am allowed to reach 15 minutes.
I talk about nutrition in cancer and immunotherapy. The power of nutrition is new concept. The father of medicine 2,000 years ago said, let the food be the medicine and the medicine be the food. Nutrition as broad spectrum of cancer control, explained from prevention to palliative care. Any of these aspects, nutrition has evolved. First, nutrition and prevention. There are multiple case-controlled studies of childhood cancer indicating that folate during early pregnancy may be important mitigating risk. Another several studies show that folate during pregnancy decreases the incidence of neuroblastoma, leukemia, and CNS tumor. So we can conclude that perimeter vitamins are associated with decreased incidence of retinoblastoma, brain tumor, leukemia, neuroblastoma. Appropriate supplementation or fortification may decrease the rate of some early childhood cancer. Take escape for prevention of cancer-causing mutation and genetic polymorphism. Diet rich in fruit and vegetable may protect the woman from breast cancer gene becoming activated. There are over 500 studies all over the world demonstrating significant protective effect of fruit and vegetables. This is some relations between the cancer and diet. Nutrition can be affected, biology can be affected by nutrition. How does actually happen? DNA methylation is important regulator of the gene transcription. Folate is necessary nutrient in the DNA methylation process. Disturbance during the early development in the methylation of imprinted gene can predispose the individual to cancer. Evidence indicates that apparent methylation patterns are involved in cancer. We know that disturbance of the gene function is a major pathogenesis mechanism of cancer. Gene function in cancer can be affected by a change in the DNA sequence through DNA mutation, deletion, or chromosomal rearrangement, or through the function. Either in the form of hypermethylation, which can lead to genetic instability and activate proto-oncogene, or hypomethylation, which can silence tumor suppressor gene and can predispose to cancer. We know some of the dietary factors known to modify DNA methylation. The most important is folate, vitamin B6, vitamin B12. All these are very important for proper methylation, genetic instability, and prevention of cancer. Just in clinical study, L-cysteine and folate increase methyl metabolism and can improve the performance of chemotherapy and reduce the side effect. Biology and nutritional therapy. Gene-nutrient interaction has great deal in the basic science research. There are targets for interfering with the tumor initiation by nutritional modulations. This is the major signaling pathways deregulated in cancer. It includes disturbance of the differentiation, apoptosis, cell growth, cancer, carcinogen metabolism, and DNA repair. All these signaling pathways can be affected by nutrition. How does actually occur? Through the bioactive food or functional food. What are the bioactive food or functional food? The food containing natural bioactive chemical compounds that have health promoting, disease preventive, or medicinal properties, such as polyphenol, carotenoid, phytoestrogen, soya, and vitamins and the trace element. So the bioactive food can affect carcinogen metabolism, immune nutrition, cell differentiation, DNA repair, apoptosis, and cell growth. To exert their carcinogenic effect, all dietary and environmental carcinogen must undergo enzymatic activations, which is known as metabolic activations in the body. These environmental toxins can be blocked by the bioactive compound present in the fruit and vegetable, which can prevent carcinogenesis by several mechanisms, such as blocking metabolic activation through increasing detoxification, flavonoid, phenols, the sulforaphane present in the broccoli. All these can block the metabolic activations and prevent carcinogen. DNA repair. Reactive oxygen species during carcinogenesis or inflammation can destroy our DNA strand. But the dietary components such as flavonoid, vitamin C, and vitamin E can help to repair the oxidative damage. We all know that the neoplastic cells have rapid proliferation. Genistein, which is one of the components of the soya food, has anti-proliferative activity, and this is through inhibition of the tyrosine kinase, which is upregulated in several types of cancer. Chronic inflammation. Chronic inflammation is a sure way of getting cancer, as during chronic inflammation. There is cell proliferation, there is promotion of angiogenesis, there is inhibition of apoptosis, and there is also promotion of angiogenesis. We have several food components which can block these processes, such as omega-3 fatty acids, which is present in the fish, such as vitamin C, carotenoid, and folate also. Differentiation. Vitamin D has very important to induce differentiation, and this is through its mechanism of regulation of the B21 and B27. B21 can lock the cyclin-dependent kinase 1 and 2, and so it can stop the cell cycle at G2M and leads to differentiations of the cell. These are some of the important bioactive food, which has broad spectrum, multi-target, anti-cancer effect. The first is olive oil. It has novel anti-cancer action, and this is merely related to its monounsaturated fatty acid, oleic acid. This can regulate the cancer-related oncogen, especially the human epidermal growth factor, which is well-known oncogenic pathway upregulated in several types of cancer. Cicolate, which has also effect on the inhibition of the RAS farnesylation, and this is another example of the oncogenic pathway. It also has effect as antioxidant, and it is very important also in the carcinogen modulation. Phenol is potent antioxidant. So this olive oil can prevent cancer through its potent antioxidant effect, and so prevent the tissue damage from the free radical. And also through carcinogen metabolism, it attacks very important oncogene pathways which are upregulated in several types of cancer. Subhanallah, حينما قال والتين والزيتون. Another is the fish, or is the fatty acid present in the omega-3 fatty acid present in the fish. It reduces the effect of prostaglandin E2, and this is immunosuppressive and pro-inflammatory. Omega-3 also has very important in down regulation and promotes the activations and inhibits the activations of mediator of cachexia such as interleukin-1,6 tumor necrosis factor. Selenium has magical ability to fight against cancer. It attacks several mechanisms. It can inhibit the angiogenesis, it can activate the apoptosis, it can promote DNA repair and inhibit the cell division. What about the nutrigenomic? It is a study of the how food affects the expression of genetic information of the individual and how the individual genetic makeup metabolize, respond to nutrient and bioactive. Nutraceutical pharmacy industry are working well. The products that are isolated, purified from the functional food and prepared in pharmaceutical form like glutamine. Nutraceutical may act as a pharmacokinetic agent, it acts as a nutritive agent and has the potential to modulate the gene function. These are some of the examples of inhibitions and activations, and we have the examples of the bioactive food within the food source. For example, the green tea. The green tea has very important phenol, which it can inhibit the angiogenesis through its inhibition of the transcription of the vascular endothelial growth factor. It also can inhibit the nuclear factor Kp, and so it can prevent the tumor invasions. Another example of activations is the broccoli, which contains sulforaphane and very important for detoxification of the carcinogens. And this is our some of the anti-cancerous food. Nutritional status and immunity. This is the major component, the amino acids. For example, the glutamine. It is one of the very abundant amino acids in the body. It is very important for proliferation of the rabbit cells, such as leukocyte and macrophage, and very important for activation of the natural killer cell, which is a very important line of defense against cancer. Omega-3 fatty acid, which is present in the fish oil, is very important in the immune modulations. Selenium, very important for our immune system to act at optimal performance. It is very important for activations and proliferation of the B and the T cell. Vitamin E is well known as immune modulator. Nutritional status and pharmacokinetic. The malnourished patient has reduced the clearance of aminoglycoside and methotrexate. Malnourished patient has increased cardiotoxicity from anthracycline. Nutritional status and prognosis. 40% of cancer patients die from malnutrition. Malnutrition at diagnosis either in the form of decreased weight or either in the form of obesity affects the overall survival. What about the nutritional status in cancer? Malnutrition is cancer is iatrogenic. Malnutrition usually occurs in advanced disease. It usually associated with poor outcome, reduced tolerance to chemotherapy, altered chemotherapy metabolism, and increased susceptibility to infections. Malnutrition in cancer affects the physiological function. It decreases the muscle mass, leads to weakness. It affects the respiratory system. It also affects the heart, muscle, and GIT. Malnutrition causing decreased cell-mediated immunity, delay wound healing, cognitive function in the form of anxiety or depression.
Time.
Nutritional intervention is very important to prevent growth and to improve the tolerance to chemotherapy for sense of well-being. But there are barriers of nutrition. I go to nutrition in hemoglobin. Just few tips. 30% of cancer patients are smokers. If you are non-smoker, the risk of cancer will be reduced by 30. 15% of cancer patients are due to hereditary. If your family line does not have any history, the risk of cancer is further reduced. Another 30% of cancer is due to poor dietary habit. So it depends on you. You can further reduce the risk of cancer by another 30 by having good dietary habits. The choice is for you. Guideline for prevention of cancer: choose a diet with variety of plant food, eat plenty of vegetable and fruit, maintain healthy weight, select food with low fat and salt, and also prepare and store the food safely. Nutrition in hemoglobinosis. There are several studies showing that there is broad spectrum of nutritional deficiency in hemoglobinosis, in fat-soluble and water-soluble vitamins and trace elements. This is due to multiple factors. Nutritional status in the patient with thalassemia may affect growth development, puberty, bone health, and immune function. Growth failure in thalassemia is multiple. One of the important functions is the nutritional status and zinc deficiency. Just the nutritional status of thalassemia and hemoglobinopathy must be evaluated annually. It also the nutritional lab, very important to be done, and nutritional counseling should be offered. Thank you.
Thank you, Dr. Eliza, for your nice presentation. The next speaker will be Professor Randa Mata, and her title will be Oxidative Stress in Patients with Beta Thalassemia Major. Randa from Chance University.
First of all, I want to congratulate Professor Dr. Amal Mishlawi for the successful conference, and thank her very much for this opportunity to give my talk. Oxidative stress in patients. Can you hear me? Yes. Oxidative stress in patients with beta thalassemia. We talk about oxidative stress, relation between oxidative stress and serum trace elements, degree of damage caused by oxidative stress, and role of antioxidant enzymes in beta thalassemia major patients. Oxidative stress is defined as the interruption of balance between oxidants and reductants within the body due to excess production of peroxides and free radicals. This imbalance causes damage to cellular components and tissues in the body, leading to oxidative stress. Here, free radicals and failure of repair of oxidative damage cause the oxidative stress. Free radical production cause affection of many organs in general, like on the heart, skin, kidney, joints, lung, brain, immune system. They are incriminated in many and several diseases. Here is the imbalance. We can see the equilibrium. And if the oxidative stress is if the active species are increased, there is imbalance, and if there is decrease in the antioxidants, also there is imbalance. In beta thalassemia, there is reduced beta globulin chains and thus increased synthesis of alpha chains, which is unopposed, leading to more fragile early damage of the RBCs. Recurrent blood transfusion causes excess iron, as you know. This excessive iron overload causes peroxidative damage, release of reactive oxygen species, and oxidative stress resultant will cause growth failure, hepatic, cardiovascular, endocrine, and neurological complications. Iron deposits, how they cause oxidative damage. Excessive iron will first saturate the transferrin, and then free iron will accumulate in blood and tissues, and will cause formation of harmful hydroxyl radicals. Hydroxyl radicals will attack the lipid, forming lipid peroxides. Oxidative stress is compensated by antioxidants, which are complex molecules that protect important biological sites from the oxidative energy. Antioxidants will keep the free radicals out, so they are very important, the antioxidants. In patients with beta thalassemia, excessive and frequent blood transfusion cause and oxidative stress cause increased free radicals and decrease in total antioxidant capacity. Use of iron chelators in combination of antioxidants are helpful to regulate the antioxidant status. What about the oxidative stress and the serum trace elements? Trace elements are vital, have vital role in to perform functions, and if are given in the proper amount, they will help to reduce oxidative stress. Example of them are selenium, copper, zinc, and iron. We'll talk about some of them. What about selenium? Selenium is essential essential constituent of glutathione peroxidase, which is important formation of hemoglobin and myoglobin. Also, it is it forms selenocysteine, which is also useful, essential in production of useful enzymes in the body. It prevents free radical damage by ferrous chloride and tin compounds. Deficiency may affect the iron binding capacity of transference. Selenium is present in nuts. Study 2001 showed decrease in selenium and decreased plasma activity of selenium-dependent antioxidant glutathione peroxidase, with increase in iron with decrease in selenium. Another Egyptian study showed decrease in vitamin A, E, and zinc and selenium and copper in patients with beta thalassemia lesion. Supplement with selenium in proper low dose selenium caused improvement in natural killer activity, improvement in natural killer cell activity. But if when they were given in high dose, there was decreased natural killer activity in symptomatic thalassemic patients. So careful use of selenium is essential in thalassemia major patients. What about copper? Copper is important. It forms metalloproteins, important component of hemoglobin. Along with vitamin C, it is important in production of elastin, which is important for elasticity of blood vessels and skin. It has antioxidant and antibacterial properties. Copper has also a central role in superoxide dismutase enzyme and in ceruloplasmin, which prevent free radical energy. It is also important in some hormones like noradrenaline and prostaglandins. Copper was shown to be increased in some studies in thalassemia. But here are the foods rich in copper. If you need copper, you should eat these foods. Other studies show deficiency in copper, so there is controversial results about copper in thalassemia. Did you see many patients with thalassemia with hair fall? Zinc is essential, another essential trace element. It has many roles in formation of hormone mediation, RNA and DNA synthesis. It takes part in cellular growth, in immunity. It has antioxidant properties as well. It is active site of some metalloenzymes. Deficiency of copper causes impaired growth. As mentioned in previous lectures today, it is important. It causes alopecia and the loss of weight. Deficiency of zinc. Deficiency of zinc is one of the factors responsible for growth and puberty in thalassemia. And zinc supplement is documented to reach proper growth and puberty in thalassemia. Also, it is important as zinc deficiency causes decrease in bone mineral density. What about magnesium? It is also vital for immune system, cardiovascular, and musculoskeletal system. And studies 2008 showed deficiency of magnesium in thalassemia major patients. Which vitamins are antioxidants? The vitamins which are considered antioxidants are vitamin A, vitamin C, E, and beta-carotene. Plasma vitamin A levels were lower in thalassemia in a study done in 2006, with vitamin E level also diminished in RBCs. Superoxide dismutase enzyme was also deficient. Another study showed the deficiency of vitamin E, E, and C in beta thalassemia major patients with and without hepatitis C virus infection. And newer study 2012 want to detect if there is dietary diminution in dietary intake, or it is diminution in the liver. So they study the amount consumed by the thalassemia patients. They found that 30% of thalassemics consume smaller amounts of vitamin A, D, E, and K, folate, and calcium, and magnesium. And that 90% have the adequate amount of riboflavin, vitamin B12, and selenium. This is American study done in Auckland. Dietary inadequacy increase with increasing age. That means with larger increasing age, they have smaller amount of intake of vitamin A, C, E, vitamin B6, folate, and thiamine, calcium, magnesium, and zinc. Okay. What about antioxidant enzymes? The important antioxidant enzymes to protect the body are superoxide dismutase, glutathione peroxidase, glutathione S transferase, and catalase. What about them in thalassemia? Superoxide dismutase is present in 3 forms: 1, 2, and 3, 1 in cytoplasm, 2 in mitochondria, and 3 extracellular. Superoxides are the main reactive oxygen species, so the dismutase is essential antioxidant to prevent the cell damage. And also it is very important inside the erythrocytes. Study done in 2005 showed higher level of erythrocyte superoxide dismutase and glutathione peroxidase with higher level of malondialdehyde in thalassemia major patients. Another study found that markers of lipid peroxidation damage such as malondialdehyde, superoxide dismutase, nitric oxide were raised in thalassemia major, while glutathione peroxidase were reduced. Another study showed that the activity of superoxide dismutase was reduced by more than 30% with diminution in total antioxidant activity. Right? Glutathione peroxidase also is important. Glutathione peroxidase activity was increased in thalassemia patients. Glutathione also showed significant elevation. Glutathione S transferase gene polymorphism was shown to be related to myocardial iron overload. Catalase is also another important enzyme which would be decreased in thalassemia major patients. Combined vitamin therapy, antioxidant vitamins were causing improvement in antioxidant-oxidant balance in thalassemia patients, which is published 2013. And finally, the administration of selective antioxidants along with essential trace elements and minerals to reduce the oxidative damage in beta thalassemia major patients still need further evaluation. Thank you.
Thank you, Dr. Rambo, for this interesting topic. And now we'll move to Dr. Muhammad Shir from Thalassemia University. He will talk about action on literacy and education.
My talk today is to present our work, occult hepatitis B infection among beta thalassemia major patients in Zagreb University Hospital, children. All we know that the thalassemias are a heterogeneous group of genetic disorders in which production of one or more globulin chains of hemoglobin is suppressed. The management of thalassemia major essentially comprise of regular cell blood transfusion and lifelong iron depletion therapy. So regular blood transfusion improves the overall cell survival of patients with beta thalassemia, it carries a definite risk of infection with blood-borne virus. Children with beta thalassemia are particularly susceptible to hepatitis B infection because they receive multiple blood transfusions. These children have a high infection rate despite vaccination against hepatitis B. Hepatitis B virus is a serious public health problem worldwide and major cause of chronic hepatitis, cirrhosis, and hepatocellular carcinoma. The diagnosis of hepatitis B viral infection is usually based on the detection of hepatitis B surface antigen. Occult hepatitis B is defined by the presence of hepatitis B virus DNA in the serum or in the liver in the absence of hepatitis B surface antigen. The prevalence rate of hepatitis B surface antigen in the Egyptian population was moderately high, about 10.1%, which is higher in Upper Egypt than in Lower Egypt, 11.7% in Upper Egypt compared to 8% in Lower Egypt, and more frequent in young adults, and more in males than females in both populations. Occult hepatitis B infection has been recognized for nearly about 20 years. It may represent an acute infection in the winter period or hepatitis B virus tail end of chronic hepatitis infection, the persistence of replication at low level after recovery in the presence of anti-hepatitis B surface, or the occurrence of an escape mutant in vaccinated or unvaccinated individuals not detected by current hepatitis B surface antigen assays. The prevalence of hepatitis C virus seropositivity in the multiple transfused beta thalassemia patient has been observed to vary greatly from 11.1 to 63.8%. This extreme degree of variability depends on two major factors: the prevalence of hepatitis C virus in the relevant population, and therefore also in the blood donors, and the practice of hepatitis C virus antibody screening before the transfusion in institute. Occult hepatitis B infection has frequently been identified in patients with hepatitis C related chronic hepatitis. Considerable data suggest that occult infection might contribute to chronic liver damage and the development of hepatocellular carcinoma. We examined 50 patients with beta thalassemia major receiving frequent blood transfusion at hematology outpatient clinic, Zagazig University Children's Hospital, from October 2010 to February 2011. The patients have been chosen with negative hepatitis B surface antibody for at least 6 months. All patients were received backed RBC transfusion every 3 to 4 weeks to maintain hemoglobin levels of these patients around 9.5 gram per deciliter. Iron regulation, difluxamine, 30 to 40 milligram per kg per day subcutaneous, 5 to 6 days a week if the iron regulator therapy used in these patients, when the serum ferritin level rose above 1,000 gram per deciliter. We divided our patients into 2 groups according to the presence of anti-hepatitis C virus antibodies. All patients were subjected to full history taking, thorough clinical examination, and routine laboratory investigation as hemoglobin level, ferritin, and the liver function test. Detection of hepatitis B virus and hepatitis C antibodies was done using ELISA. PCR for detection of hepatitis B antigen was done to all patients. This table shows a descriptive analysis of the study group, which show that the age of our patient is about 11 years old. The male were more 60% and female about 40%. Most of our patients are irregularly related, 66%, and only 34% are irregularly related. The hepatitis C virus infection was found in 44% of our patients, and 56% have negative for hepatitis C antibodies. The positive PCR for hepatitis B antigen was found only in 4 patients, about 8% of our patients. This table shows the laboratory parameters according to the presence of hepatitis C virus antibody. This table shows there is no significance according to in the occurrence of occult hepatitis B in both groups. However, there is slight increase in the number of patients with hepatitis C positive than those with hepatitis C negative. 3 patients in hepatitis C positive, about 13%, while only 1 patient with hepatitis C negative, about 30.5%. In conclusion, substantial proportion of hepatitis B surface antigen negative thalassemic patient was under occult hepatitis B viral infection in endemic areas for hepatitis B infection as in Egypt. Thalassemic patients were prone to frequent blood transfusion, so they are at high risk for hepatitis B infection. Therefore, more sensitive methods like PCR should be applied to identify occult hepatitis B, and more meticulous attention should be given to prevent hepatitis infection in endemic areas for this virus. And thank you.
Thank you, Professor Bashir, who attached the slide exactly. Now we shift to Professor سهام رجب. طبعا بتضحك لان انا ثالث مره على التوالي اقدمها وابقى انا اللي بقدمها ب3 مؤتمرات على التوالي في خلال شهرين.
Thalassemia is an inherited developmental disorder. As we know, high incidence of thromboembolic episodes have been found in beta-thalassemia patients that could be attributed to interplay of profound endothelial accumulation, immunomodulation, and a characteristic rather anti-atherogenic plasma lipid profile. Premature atherosclerosis have been documented in beta-thalassemia patients in several studies. The most physiological hallmark of atherosclerosis is a combination of lipid accumulation with enhanced inflammation within the vesicle wall, hence the interaction of lipids with various inflammatory cells, especially monocyte, macrophage, and T cells. Low protein-associated glycosylates A2 is an enzyme produced by hematopoietic cells, primarily from monocytes and macrophage. During the hydrolysis of oxidized phospholipids, this enzyme generates lysophosphatidylcholine and oxidized free fatty acid, both of which exhibit pro-inflammatory and pro-atherogenic activities. Other several inflammatory mediators are involved in atherosclerosis as we know process, including tumor necrosis factor alpha. Common carotid artery intermediate thickness is a surrogate marker of generalized atherosclerosis. It is well known invasive, visible, reliable, and inexpensive method for detecting development of subclinical atherosclerosis that can indicate future cardiovascular disease. The objective of the present study was to investigate the level of lipoprotein-associated glycosylates A2 and tumor necrosis factor alpha in beta-thalassemia children and relating them to subclinical atherosclerosis. This study included 42 beta-thalassemia children, 22 thalassemia major, and 20 thalassemia intermediate, with 30 healthy children of mentioned age and 6 other control. We selected the control to be of normal lipid profile and without having history of hypercholesterolemia. And the exclusion criteria in our thalassemia patients are we exclude any acute illness and patients with diabetes mellitus and those with any abnormal echo findings, especially by ventricular systolic function. Each participant is subjected to the following: chemistry taking, paraclinical examination, laboratory investigation includes CBC, serum ferritin level. For the patient, we take the median serum ferritin level in the previous year was considered on the average of 3 determination for each patient. Lipid profile was done included cholesterol, triglycerides, low-density protein, and high-density protein with low-density to high-density protein cholesterol ratio estimated. Associated A2 and tumor necrosis factor alpha level were estimated using another technique. We do echo and ECG for each participant. Carotid intermediate thickness was measured by high-resolution labial ultrasound. The maximum thickness of the intermediate was measured to get 3 reading, and the mean value was used for statistical purpose. We define indicative value of intermediate thickness measurement where defined bounds above the 95th percentile of a healthy control subject. Results? This table illustrates the clinical demographic presentation of the control and thalassemia patient. We consulted on the hepatitis C that more prevalent significantly in each thalassemia group compared to the control, and also in thalassemia major patients significantly than thalassemia intermediate. Comparison between the included groups regarding the investigation parameter, as we know serum ferritin high serum ferritin level was significantly higher in each thalassemia patient major and intermediate compared to the control, without significant difference between thalassemia major or intermediate. But regarding the level profile, the only parameter that was to be found higher in thalassemia patient is the driving stride. Was to be found higher in each patient group compared to the control group, and also is found to be higher in thalassemia intermediate compared to thalassemia major. While the other parameter, fetal cholesterol, high density lipoprotein, low density protein cholesterol, and the estrogen ratio, LDL to HDL ratio, was found to be significantly lower in each thalassemia group compared to the control, without significant difference between each to the other. Human glucose factor alpha and lipoprotein associated phospholipase A2 was found to be significantly higher in each group compared to the control group, and also was significantly higher in thalassemia major group compared to the control group. Regarding the marker of atherosclerosis, the intermediate thickness was found to be significantly higher in each thalassemia group compared to the control group, without significant difference between thalassemia major or thalassemia intermediate. This defining of inconsistency in the study groups higher in thalassemia major, thalassemia intermediate compared to the control, and this is the difference in lipoprotein associated phospholipase A2 and human glucose factor alpha. Then we categorize our patient to those with elevated intermediate thickness and those without elevation, and we could take the cutoff point of the above 95th percentile of the normal control to be the cutoff point of the elevation. And when we do percentile, the point of 95th percentile is above 0.5 millimeters. So comparing between patient with cut in the thickness above 0.5 millimeter and those below this level, the serum ferritin will also have to be significantly higher in patient with elevated blood thickness compared to those without elevation. Also, lipoprotein associated phospholipase A2 and human glucose factor alpha were found to be significantly higher in those patients with elevated carotid intermediate thickness compared to those with non-elevation carotid intermediate thickness. We do correlation study. Carotid intermediate thickness, the marker of atherosclerosis, significantly correlated to serum ferritin level in the whole group and in each thalassemia major and thalassemia intermediate. Also, is correlated significantly and positively with lipoprotein associated phospholipase A2 in the whole group and in each subgroups. The same for human glucose factor alpha that correlated significantly with carotid intermediate thickness in the whole group and also in the subgroups. But it is correlated negatively with the hemoglobin level in the whole group only. Lipoprotein associated phospholipase A2 was found to be correlated, and the human glucose factor alpha correlated positively with ferritin in thalassemia major group only. We do multilinear regression analysis showing that serum ferritin level was the only significant risk factor for increased carotid intermediate thickness. The data obtained from the row curve denote or with that serum ferritin level at the cutoff point of 2,176 and sensitivity of about 70%, sensitivity of about 75% to predict the occurrence of increased or negative carotid intermediate thickness. Also, the area under the curve of the lipoprotein associated phospholipase A2 were higher, about 1.74, with a sensitivity of about 50% and specificity of about 99% for detection of carotid intermediate thickness enlargement or elevation. Conclusion: thalassemia children are at risk to develop subclinical atherosclerosis and not correlated with iron overload and can be predicted by serum ferritin level. Plasma level of lipoprotein associated phospholipase A2 and human glucose factor alpha were significantly elevated in beta thalassemia children and showed a strong correlation with carotid intermediate thickness, suggesting that they may be modulating the factor in the pathophysiological process of carotid atherosclerosis in these patients.
She's working in the National Research Center and the title would be liver enzymes in children with beta thalassemia major, correlation with iron overload and iron hepatitis.
Beta thalassemia is the most common genetically defined chronic hemolytic anemia with an estimated carrier rate of 9 to 10.5%. Transfusion therapy is the main line of treatment of thalassemia patients. Accordingly, iron overload is often inevitable, especially when iron-chelating agents are not used properly. Transfusion-associated infections show high prevalence rate. The most common of these infections are hepatitis C and hepatitis C. In Egypt, the prevalence rate of hepatitis infection in thalassemia patients was 74.2%. Although the risk of post-transfusion hepatitis C virus infections dropped significantly after the national screening of blood in 1993, it is still high. In 2011, a prevalence rate of HCV antibody seropositivity in thalassemia children was 51.7, and it was 48% in 2012. Iron overload and hepatitis C virus infection have been implicated in the evolution of liver disease in patients with transfusion-dependent beta thalassemia major. And the relationship between iron overload, HCV infection, and liver injury is still controversial. Injury to liver, whether acute or chronic, eventually results in an increase in serum concentration of ALT and AST. Our study aimed at evaluating the potentiating effect of iron overload and viral hepatitis infection on liver enzymes in Egyptian children with thalassemia major, and trying to throw light about the percentage of HPV and HCV in the studied thalassemic patient. This study was conducted on 80 patients with beta thalassemia major, who were recruited from the hematology clinic in New Children's Hospital, Cairo University. Their age ranged from 5 to 18 years, and informed parental consent was taken. Inclusion criteria: patient diagnosed as beta thalassemia major, their age ranged from 5 to 18 years, and were undergoing regular blood transfusion, and had clinical follow-up for at least 24 months before the study. Any child with a history of liver affection was excluded. The children included in this study were subjected to thorough demographic and medical history, including regimen of management, complete physical and clinical examination. Blood samples were collected for laboratory investigation, which include iron status, serum ferritin, serum iron, total iron capacity, and transferrin saturation, and liver function, serum level of ALT, AST, and gamma GT. Detection of hepatitis viral infection done by hepatitis B surface antigen, anti-hepatitis C virus antibody, HCV PCR testing for anti-HCV positive patients. 93.7% of our patients are on iron chelation. 71.2 were receiving difluran, while 22.5 were receiving difloxamine. Only 6.2 didn't receive any iron chelation. Here we find that the mean level of
more specific because light scatter is very easy. So if light is scattered, it will not emit
the dye, and you would not see the cells. However, the lumen is closed, so when the probe entered inside with the light was collected and the cells were fluorescent. And it was very easily shown that upon light passage, you can see the cells fluoresce and become dark again, because when the light crosses, it's not. We just do impulses of light. Of course, it's a huge teamwork because this is a lot of work. First, it's about 5 years of work. It's not 1 year or 2 years of work. It's about 5 years of work, and we got rejected several times. And for the first answer, in order to, after receiving rejection, it was about 6 months. So if it's about 4 months or 4 years of work, we had about 1 year in order to make it published again. So we had a rejection after 6 months, and the application was not accepted. So we had to reapply in another journal, and they made a major revision, and they said we didn't ask. They just said you have to prove it's a lumen. They just left it to us. So, but honestly, we didn't take much time in order to prove this. We just repeated the experiments, and we had the vascular tubes, and we had the idea of passing the light. It was not.
That is not a real difference, but the difference actually was to reduce the distant recurrence, which was only seen during the first 2.5 years in 7% in the attack study and in 27% in the big study. And just to remind you that what is really killing to our patients is the distant recurrence. However, the Data Monitoring Bureau, for ethical reasons, in this kind of studies, when you have a double-blind study, head-to-head comparison between two drugs, when you find that one drug is clearly superior to the second drug, then you have to offer the better drug to the patients for ethical reasons. And what was done actually after the data I showed you of 26 months, 25% of the patients who were originally randomized to receive tamoxifen, actually they crossed over from tamoxifen arm to letrozole arm, which really complicated the statistical analysis. And actually, these patients, they received this drug for an average period of 18 months within the 5 years. So we started with an intent to treat. At 26 months, we analyzed these two arms like this. But in the longer follow-up, 25% of the patients were no longer receiving tamoxifen and they received letrozole. So this made life very difficult for the physician. How can we analyze this? And that's why now, because of this design of studies, which allows for crossover superior drug, now we have a new way